Yeah, okay, cool. Awesome. Thanks, everyone. So it's awesome. Thanks for everyone for joining us. It's really, really awesome how many people we've got here today. What we're going to be looking at doing, I'll go backwards actually, is we're going to go through 4 cases, and it sort of started on slide number 1. But we're going to go through 4 cases today, and we're going to try and get out of it as well just some general points, and it's going to relate to how we sort of manage patients at the current environment a little bit, but obviously we're pretty restricted on what we can do at this point in time. But then otherwise, the 4 cases, we're going to do a MIH, molar incisor hypomin, permanent tooth trauma, dental caries, and primary tooth trauma. With regard to like any questions or anything that anyone may have, we've pretty much muted everybody because otherwise it gets very challenging. So if you get any questions, you can just type them into the chat box and we'll get them, and we'll do them all at the end. Similarly, you can send a private message. So if you're concerned about asking a question, please feel free to ask through as well. So the first case we're going to look at going through today is molar incisor hypomineralization. So we're going to present each case sort of just working our way through and try and give you some thinking and sort of get everyone sort of trying to work out what the most appropriate treatment is here. So the patient that's presented is fit and healthy, 9 years and 10 months. So it's a pretty common age to see an MIH affected patient. Oral hygiene's pretty good and diet's good. Their main concern is they've had several fillings placed with and without local anaesthetic, and they bloody hate the triplex. They're also pretty anxious when they attend the dentist. And their main concern is that they're getting quite bad sensitivity on their back teeth, and they've got some temporary restorations, and this is what they were referred for. So when we do our intraoral examination, you'll see that the 3/6 photo on the occlusal's actually got quite a sizable restoration in there, and that's a GIC restoration place. But that's the photo of the tooth up in the top left corner, what was looking like prior. Even though, let's say, for example, the patient presented with the tooth looking like the 3/6, even with the current period of time we're dealing with, we still want a comprehensive oral examination to go through. The reason is, sorry, is everyone seeing the screen? Yeah, I think might just be you, possibly. So sorry, just say, yeah, look, what we need to do is, even in the current environment, we need to have a comprehensive oral examination conducted, and you're going to see why for all the cases why we need to do this. So you still would go on an 011 pretty much for all these kids, even if you're seeing them for an emergency. The reason is you need really, really good planning here to work out what's going to be the most appropriate thing for them. So in this case, what we're looking at now, we can see that there's sort of a bit of gingivitis around. There's sort of severe MIH, which doesn't actually look too bad clinically. On the 2/6, we can see that temporary GIC restoration. The 3/6, which as I said, looks quite good, but we do have that pre-op photo, and the 4/6 as well. There's also a sort of milder defect on the 1/1 there, but there's no other carious lesions that we can detect. So similarly, we're going to be looking at going through, and we want you to do a full radiographic examination as well. So let's just say that hypothetically they attend with the 3/6. It's also really important to take bite wings on the other side, and you can see why, because you know they've got the same issues occurring on the right-hand side as they do on the left-hand side. And gathering this information, even in the current environment, is still really important to do. Just an incidental finding, we've got the 5/5 distal, sort of an enamel-limited carious lesion, but you can see the severity of the MIH on the 3/6 and 4/6, and you can see some restorations present in the 1/6 and 2/6. This is actually usually the reverse of what you see. Most commonly, we tend to see clinical presentation that's far worse than the radiographic presentation. So the next step, which we need to do, is get an OPG. This is, Sarah and I don't recommend OPGs routinely for kids, particularly not if you're dealing with quite young children and you're able to get away with bite wings and things. But for anyone with an MIH, we definitely want an OPG. The reason is we need to work out where they are now and work out what type of dentition is developing here. So you can see the crypts of the 3/8 and the 4/8 developing, while the 1/8 and 2/8, there is, you can see just some sort of white circles, radio opaque circles from there, and that's a really quite a solid indication that you've got a 1/8 and 2/8 developing. It's not guaranteed, but it's pretty important. You can also see there's no developmentally absent other teeth or any other significant issues. Possibly there's a little bit of an ectopic canine on the 1/3, and the 2/3 looks slightly, but not too bad. So what's our diagnosis list? And this is what we need to do for pretty much all our patients, the same as what you do for an adult. Well, we've got generalised mild plaque. We've got that sort of one mild carious lesion, but we do have this severe molar incisor hypomineralisation with post-eruptive breakdown on the 2/6, 3/6, and 4/6. A really important thing to gather at this point in time is what their orthodontic relationship is. And he's quite routine, actually. He's class 1 molar. He's slightly retroclined 1-1-2-1, but he's got a bit of mild crowding in both arches. So we pretty much have all the information we need now. You can try and do sensitivity testing to see if these teeth are vital, but the kids will usually tell you if you try and pick the triplets up. So we would recommend that if you ever see a patient with MIH, don't actually blow air on their teeth because they will really dislike it. So now we look at it, we've got all this information. Let's look at what they are as a whole, and not just the initial concern of that sensitive molar. We will get to addressing that, but let's address everything. So what we need to consider here is that this patient's 9 now. They need a long-term plan. You know, they've got upwards of 80 years left of these teeth. And what is the cost of doing something now? What's the lifelong cost for care? So these kids get up to 10 times more dental treatment than unaffected children. So we need to try and minimise that where possible and minimise their costs, as I said, lifelong. Most parents are going to be pretty keen on having a nice planned out lifelong plan for their children rather than doing things sort of on an ad hoc basis. So what are our options available? We can temporise the teeth with GIC, and we can add some silver diamine fluoride. We will discuss, for those that are not familiar with silver diamine fluoride, I will discuss it in the 3rd case we're presenting. The other options are we can restore the teeth with resin composite, we can restore them with stainless steel crowns, or we can look at extracting the affected molars and possibly also unaffected molars. And what we mean by balancing or compensating there is that when you balance an extraction, for example, if you're taking the 2/6 out, you might also consider taking the 1/6 out. And if you're compensating, that means if you're maybe taking the 4/6, you might take the 1/6 at the same time. And this is where having a really good guide on the occlusion is really, really important. So what we're going to do now for a little bit is actually just talk through the different options. Sarah and I aren't going to put too much literature up and data and things like that. We're just going to try and work through what we've got. So look, if we temporise the teeth with GIC plus or minus silver diamine fluoride, which is like that's a desensitizing agent. So it sort of maybe lets you get treatment a little bit more successful. The question is going to be, look, where's this going to leave the patient? And the answer is the condition will continue to deteriorate. It's just going to deteriorate at a slower pace. So look, that's really not a long-term option. In the current environment with level 3, you know, if the child's not wonderfully compliant and we're not comfortable extracting teeth, which is the only other option we've got in this case, yeah, look, you know, that's when we would consider temporising, because that's going to buy you 3 to 6 months of time. But when you're dealing with more longer term care here, that's really not a viable option. And no matter what you're sort of told at university days about how GIC is the godsend restorative material, it's not going to fix these teeth. The other option is you restore them with resin composite. Look, that can work. The issue that you've got is that resin composite requires enamel to bond it to. And in these kids, the quality and the quantity of the enamel, particularly in this boy's case, is really quite poor. And he's actually had the 4/6 previously restored with resin composite, which has now failed. And that's no one's fault. That's not the practitioner's fault or anything. These are just incredibly challenging teeth to treat. So if you are treating a patient with MIH and you decide that, look, we're going to restore these teeth with resin composite, you actually need to get the margin onto sound tooth structure. So that means you do need to sacrifice a fair portion of tooth structure, but you will improve the longevity of your restoration. So you may be able to see the upper occlusal photo where the 2.6 is, where they've got that temporary GIC in at the moment. You can imagine if you decided to restore that with resin composite, it's going to be pretty big, and you would have to extend it down quite far palatally to get onto a healthy margin. What is a healthy margin? The only way we can really tell is it's just a visual assessment. You just have to think what looks pretty healthy here. The next option is a stainless steel crown. Now, everyone always thinks paediatric dentists love these, and look, in cases like this, we really do. This would really require a minimal preparation to the tooth. So you'd put a separator in the teeth prior, you'd do some occlusal reduction, and you really would not actually try and remove too much of the defect and sort of seal it in with the GIC. This is a semi-permanent restoration. So this will get you through to about 18, 25. They can stay longer, but your periodontal tissues are not wonderful with this. So realistically, this is something like maybe if you've got one tooth that's affected by this and the rest are perfect, and maybe they don't have 8, so you can consider this as an option, with the understanding that the patient's going to be looking at a permanent crown when they've finished their development. So you can imagine in a case like this, look, that's a viable option. It's much more viable than restoring the teeth with an intracoronal restoration. The issue is that we've now sort of signed this patient up to 3 crowns when they're 18 or 25. So we're looking at, $5,500 there. Look, it's going to last longer than constantly patching up restorations, which is more likely to end in root canal therapy and then a crown. But you're still going to be staring down the barrel of a substantial cost here. The other option, which seems quite drastic in a lot of cases, is that we actually look at removing these teeth. So we look at removing the 2.6, 3.6 and 4.6. And the question we have to ask is, the 1.6 is unaffected. It looks perfect. And this goes to show how strange MIH is. All these teeth grew at the same time, and they all have variable impacts. But why would we take the 1.6? Well, it's got nothing to occlude on. It's a class 1 occlusion. So we would really have to consider removing that. Otherwise, the 4.7 will erupt, and it will actually prevent the mesial migration of it, and you'll have an over-erupted 1.6. So we would probably be looking at sacrificing the 1.6 in this case as well. What's the pros of that approach? Well, look, these teeth, if we do try and patch them up, are estimated, there's a nice study done on this, at costing individually each tooth $25,000 over the lifetime of the patient. So you're looking at $75,000 a cost for this patient. Now, if we look at extracting, that's US dollars, by the way. If we look at extracting these teeth now, your costs might be that the patient needs orthodontics, and they were already considering orthodontics to potentially tidy some things up, which is going to be a little bit more prolonged because it may be more challenging to mesialize those lower 7s. However, you've essentially avoided wisdom teeth surgery for this patient. He's likely to get healthy molars extracted when he's 21. So why don't we remove these teeth that are terrible when he's 9, and we actually look at preserving what are relatively healthy teeth? A common question we get asked as well is, what about the 7s? Are they also going to be affected? They are more commonly affected, but to a far lesser degree. And you're not really losing anything by losing this set of terrible 6s. So in this sense, the most appropriate treatment for him is going to most likely be extraction of all 6s. What would we do in this sense? As I said, if the patient presented with the 3.6, it does take a fair bit of consultation to get to this point. And a lot of the times, if they are quite complicated orthodontically, Sarah and I will we'll refer them to an orthodontist just for a consult now. There might be no treatment required, but it just sometimes helps us make a decision. Some patients don't ever want orthodontics, and then we will make that decision with conjunction of the parents and discuss the pros and cons. And then if you guys are in your general practices, most orthodontists or pediatric dentists like ourselves will be happy to give you some advice in regards to balancing and compensating extractions if they don't have an option to come down. And we've done that quite commonly with the public service up here. So look, what could you do now? Look, if they're presented with a really sore 3.6, it wouldn't be unreasonable to discuss with them that, you know, rather than patching this up, we could consider removing it. And if we removed it, would we also take the 2/6 at the same time? Or something that's quite reasonable at this time is you just temporise that tooth, but you can have the discussion with them now that, look, this is not long term. We're in a unique situation at this point in time, but we need to consider removing these teeth down the track, and let's just start getting that idea in their head. When we're considering extracting some of these teeth, there's a really good guideline. The Royal College of Dental Surgeons in the UK released a really nice guideline for what teeth you should extract, and they've actually got a section there on emergency treatment. So if a patient presents to you with, for example, facial cellulitis or really acute pain, and their recommendation there is, look, just take the affected tooth out, but then look at planning further ahead for this patient when they're a little bit more comfortable. Other things to consider, and this is why occlusion is so important, sometimes you might actually decide to delay the extractions, or you might do the lower arch first and allow maximal natural migration of the sevens, but hold the upper sevens for some time. So this might occur if the patient's quite crowded. So what you can do there is you hold that space, and then you can use that to retract and address some crowding, and that's where it's quite important to get your orthodontist involved as well. You can see these are big teeth. Those are 3. We did end up taking all 4 6s out. Those are 3. I don't know where the other one's gone, but you can imagine these are big teeth. Sarah and I are big fans of avoiding general anaesthetics wherever possible. But on a 9-year-old child, sometimes to do 4 of these teeth in the chair can be quite an ask, even on a really compliant child. And the main reason is, look, there's a bit of force involved, as you would all know, extracting molars. And the other issue too is that with hypomineralized teeth, there's abnormalities with the pulp. So sometimes no matter how much anaesthetic we put in, even with 60% nitrous oxide, the patient still feels it. So if you got 1 or 2, yeah, definitely that's really reasonable to do in the chair. When you're looking at 4, it's really a discussion you got to have with the parents about what's involved here. And if they don't have an option, they can't afford general anaesthetic, you know, of course you'd consider it in the chair. But these are really quite involved teeth. So that's the MIH section done. But as you can sort of see, Sarah and I are pretty keen on anything that's sort of getting more severely affected, actually considering removing these teeth. What I'm going to do now is I'm going to pass over to Sarah, and she's going to run you through the next case. And I said, if you get any questions, you can you can write them down or send them through, and we'll look at addressing them at the end. Thanks, boss.
Right. Good evening, everyone. So now I'm going to go through permanent tooth trauma that happened to a 12-year-old fit and healthy boy. One of his friends threw a metal drink bottle towards him, and it caught his tooth number 11. There is no other injury. He did not hit his head. There is no loss of consciousness, no vomiting, nausea, and no neurological deficit. We saw him 6 hours after the trauma happened, and actually Tim was on call for SCU that day, and I went in to help assist him as it was the weekend. So for any orofacial trauma, we run through a set series of questions similar to the International Association for Dental Traumatology Assessment. If you would like more details, you can consult the IADT website or email us. But traumas can be quite stressful, and we want to make sure that we're not missing anything. So it's good to have a routine for traumas. In addition to the extra-oral examination and the neurological assessment, we also conduct an in-depth intraoral examination, including evaluations of soft tissue injuries, presence of foreign bodies, bony discrepancy, changes in occlusion, and the examination of all teeth to make sure we're not missing anything. We look at mobility, fractures, missing or displaced teeth, and we perform vitality testing on all involved or potentially involved teeth. So the findings for this boy that you can see on the photo included in age-appropriate mixed dentition, generally good oral hygiene, a complicated crown fracture of tooth number 1-1, no mobility, sensitive to, the tooth number 1-1 was sensitive to air and drinks, positive response to cold. There is no displacement or excessive mobility. The tooth was tender to percussion, and there's no damage to neighboring teeth or the lower dentition. Also, for any radiographic assessment of trauma, you're likely to require several radiographs, and to standardize them, we like to make a putty key that you can save and reuse when the patient comes back for his follow-ups. So this allows you to ensure that the radiographs are reproducible and that you can also keep track of changes better. Exact angulation can be quite difficult to obtain from one appointment to the other without it, even when you're using the XCP system. Another good option would be to get a low-dose radiation CBCT, but not everyone gets access to that in their clinic. So the radiographic findings for this patient included a complicated crown fracture of tooth number 1-1. There's an increase in the lamina dura width around the apex of number 1-1, possibly indicating a very mild luxation injury. It's a fully developed root length, but it still has quite a large apical opening. We also noted a small line in the apical third of tooth number 1-1, which could be an artifact, as it was not visible on other radiographs we've taken at follow-ups, or it could be just a small fracture. However, even if it's just a small fracture, given that the tooth was not mobile, no treatment would have been indicated in the follow-ups that we were already doing. There is no significant displacement and no damage to neighboring teeth. So the diagnosis for this patient included a complicated crown fracture of tooth number 1-1 with a possible very mild luxation injury, given the increased lamina dura noted on the radiograph. However, the patient and his parents did not notice any changes in the position of the tooth, and also there is no damage to the remaining teeth. So in grown children, ongoing vitality is crucial. This is what dictates our treatment. In children, we have incomplete development of the teeth and jaws, and as such, we need to promote normal growth and development as much as possible. This is a rather simple case, but in all trauma cases, this is the priority and guides your care. For example, sometimes you may not have the most ideal or recommended material available to use, and it may be worthwhile during this time trying to familiarize yourself with these materials. This is because when we're treating children, the consequences of a complication are far more significant than in a fully grown adult. So anything you can do to improve the success is important. Even in adults with new bioceramics, the chance of healing has improved. We now know that we can also successfully treat complicated crown fractures several days later. We just need to get down to a healthy pulp. With the right diagnosis, particularly the presence of a vital pulp without irreversible pulpitis, the success rate of a Schweck pulpotomy is over 95%. Materials applied directly to the pulp must not stain. That's a failure on an anterior tooth. So you want to avoid conventional MTA materials, as significant discoloration can be observed after treatment, even with the white MTA that will discolor, not so much because of the color of the product, but because there's a reaction with the bismuth oxide in the MTA in the blood. So I've just put a photo here of a patient I treated years ago at a hospital back in Canada. That was after significant orofacial trauma. So unfortunately, she had a lot going on, and we had to treat her under general anesthesia. And I could just do the emergency treatment, that is the Schweck pulpotomies. And as you can see, when the patient actually returned 2 weeks later, there was already quite a lot of discoloration from the MTA. and it actually commonly gets worse with time. So this was the last time I used MTA for anterior uvectopotomies. Now I'll run through the individual step for uvectopotomy with the most up-to-date materials. So first you need to isolate the tooth. This is important now for any treatment with aerosols that we're doing, but equally so in normal times. So when you do your uvectopotomy, you have to use coccus irrigation with the high speed and remove about 2 millimeters of pulp. You want to use a new diamond burr so you limit the risk of shredding the remaining pulp. You may have to remove a bit more than 2 millimeters if the pulp is bleeding quite a bit, because you really need to get down to healthy pulp. Hemostasis should be obtained within 5 minutes with a wet cotton pellet. Once hemostasis is obtained, we also clean with a cotton pellet that's been dipped in sodium hypochlorite. Then you place a bioceramic material such as biodentin on the pulp. You need about 2 to 4 millimeters of material to obtain a good seal. We like to place it with an amalgam carrier, as this way you can get a good bulk of material. If you do not have a bioceramic, you could use calcium hydroxide. So first you put a non-setting one, and you cover it with a setting type of calcium hydroxide. However, the success rate is lower, but if that's all you have, I guess that's what you have to use. If you only have MTA as a bioceramic, then you have to place it below the CEJ so it does not stain the crown. So after the bioceramic, we normally place a resin-modified glass ionomer to go a bit faster with the placement of a permanent restoration, as the setting time of biodentin is 12 minutes. And actually, I tried to look at the literature, but I couldn't find the reason why the manufacturer is actually recommending to wait 48 hours to do the final restoration if you want to put it directly on biodentin. Alright, so once a tooth is stable, we now concentrate on restoring the aesthetics. Here's what we do when the patient comes with a tooth fragment. First, we'll remove the dentine in the middle of the fragment to accommodate for restorative material that will hold the fragments together. Then we etch the fragment and tooth for 20 seconds. We apply the primer, the bond, we cure, and then we will fill the fragment with composite resin. We like to use a composite resin instead of a flowable composite because it helps to stabilize the fragment before we cure it on the tooth. After we seat the fragment, we remove the excess composite and we cure. You can see on the first photo how the thicker composite material helps keep the tooth fragment in the right position. So you don't have to worry about the fragment moving too much as you remove the excess composite and cure it in place. After curing the fragment in the right position, we bevel across the fracture line to improve aesthetics. It will also involve more enamel surface for adhesion, which could improve retention of the fragment. Finally, we cover the bevel with composite and we polish the tooth. On occasion, it may not seat perfectly or you'll have a bit of spacing, so you can use resin to fill in the gaps, and that's when flowable composite comes a bit handy. So here's the patient right after the treatment on the left-hand side, and 1 month later. You can see on the follow-up radiograph that a dentin bridge has already started forming, and aesthetically, there's a pretty good result. So now, although it does not relate to this case, I'll now discuss some important points for trauma. One of these is splinting materials and what has changed recently. So with any splint, we've worked out that physiological mobility is paramount in ensuring that you have more successful outcomes, particularly to avoid ankylosis, which is catastrophic in a growing child. Also with splinting, depending upon which guidelines you read, some say 1 tooth on either side and some say 2 teeth on either side of the traumatized tooth or teeth. I generally like to splint at least 2 uninjured teeth on each side because personally I'd rather be safe than sorry. I've seen teeth debonding before, and in an anxious child, it really is a nightmare to try and correct that, and the tooth can move as well. The materials that are available for splinting include fishing line, usually ideally a 20-pound one, and composite resin. It's cheap and easy to do. Also, the advantage with that now is that when it will be time to remove this splint, you can actually just cut the fishing line between the teeth until high-speed instruments can be used again. For the composite, if you want to limit aerosols as much as possible, you can use a one-step self-etch adhesive system like Scotch Bond Universal. We don't really like GIC for splint, as we've commonly seen debonding. You can also use composite resin and an ortho wire to make it a flexible splint. The wire diameter needs to be under 0.4 millimeter, which is an 016 wire or under. Some people also like to use brackets and ortho wire, but if you do so, you must ensure that your brackets are perfectly placed, or you've got amazing skills with wire bending, because you absolutely do not want to apply any orthodontic forces. Finally, you can use a fiberglass splint. It's a great splinting material, but it can be quite expensive. And when splinting, please make sure you have hemostasis. It's very hard otherwise. So in the current context, try to clean the teeth as much as you can with the wet gauze. The second point to raise is how important reviews and follow-up appointments are. They're crucial in ensuring that you can detect a complication as early as possible. As I mentioned earlier, complication in an adult is far less catastrophic than a growing child. As an example, this is a child that presented on referral for management of an avulse number 21. It had a 45-minute extra oral time, but it was kept in milk. Given the immature apex, it was decided to monitor the tooth instead of extirpating the tooth. The tooth was reviewed at 2-week intervals for root resorption, and actually the radiograph on the left was 4 weeks post-trauma. We were not certain of the prognosis, so we decided to wait another 2 weeks. You can see how quickly on the radiograph on the left, you can see on the right side how quickly the resorption progressed. Therefore, this highlights how important it is that you emphasize to parents why you do the reviews. And on to Kim.
Awesome. Okay. So the next one we're going to run through, this is a bit more bread and butter for all of us, which is sort of dental care is in a young child, but similarly can apply to a bit more of an older child as well. So this is a 6.5-year-old. He's got sort of moderate asthma. It's relatively well controlled. His diet history is pretty moderate to high risk. His oral hygiene is pretty poor, and he's only ever really had dental examinations before. His compliance is moderate, so he's okay for exams and x-rays, and we're a little bit uncertain, how would he go with treatment? His main concern is that he's got an abscess or a pimple on his upper right-hand side, and he's got sort of short, sharp pain on his lower left-hand side, but it's only when he's eating. So when we do his intraoral examination, he's got pretty good oral hygiene actually, even though in the report he doesn't brush too well. He's got quite sort of pronounced hypomineralized, hypoplastic sort of defects on the 3-1 and 4-1. And you also see a bit of hypomineralization on the 5-3 buccal. He's got that quite sizable carious lesion on the 5-4 and also a smaller one on the 7-4. So similar, like what we discussed with the MIH case, and like with all of these, even though the patient's presented to you with the 5-4, that's their main concern. We want you to look at everything, even in the emergency examination. And I know sometimes that can be a bit challenging. But it really will make things a lot easier for you longer term. So you don't necessarily need to do treatment on the first visit. So look, if we decide that, look, we want to do some treatment here, we really need to get radiographs, and not just the area where we've got the tooth. The issue with radiographs is in children, it's really quite challenging to get them. But why do we get them? It's because we miss half of the carious lesions in kids' teeth without radiographs.
And the other issue that we tend to find as well is that, nearly 90% of restorations that are not great are only picked up with radiographs. So, the two x-rays that are in the middle, they were taken 1 week before the one on the right-hand side, and the practitioner who restored that 7-4 didn't have access to the radiographs. So they couldn't really assess the depth of the carious lesion. They didn't use local anaesthetic. Then the kid's compliance failed before the end of the appointment because they were getting quite close to the pulp. So they've now had a restoration that's placed that's will need retreatment again, purely because they didn't have the radiographs with them. So I would really encourage you to take radiographs wherever possible. And in this case that we're talking about, you can see why it's quite important. The 5-4's pretty badly bombed out. The 7-4 we know is quite sizable and it's getting quite close to the pulp. But we can also see that there's early carious lesions on the 6-4 distal, 6-5 mesial, 7-5 mesial, a larger one, in fact, in a third, sort of nearly halfway, the dentine on the 8-4, and the 8-5, sort of enamel just into dentine, limited one there as well. So we would have not picked up those other lesions without taking these radiographs. And what you don't see, you can't treat. And it doesn't necessarily mean invasive treatment, but you can't also prevent these lesions either. So what are his diagnoses? Well, he's got a large carious lesion with necrosis on the 5-4. He's got cavitated carious lesions on the 7-4 and 8-4. Well, how do we know the 8-4? Generally speaking, most carious lesions that are into the outer third of dentine are cavitated. If they're at the DEJ, they're not. And that's why we've decided 6-4, 6-5, 7 are non-cavitated. It's also got moderate hypomineralisation. We're not going into that. So the questions we've got to ask are, look, what's this boy's complaint? How much treatment does he need? And how are we going to treat him? The other really important thing we've got to consider is how long does he need these teeth for? Because it's very different with a 2-year-old, a 6-year-old, or a 10-year-old. Okay, is he going to get ongoing growth and development impacts like space loss? And what's this long-term psychological impact of the dentistry that we're going to be doing? So in this sense, we know the treatment options available. The 5-4 has to be an extraction. It's just do we do a space maintainer there as well? With the 7-4, our options go from very conservative, so silver diamine fluoride or fluoride, a GRC blob, hall crown, which I'll review for people in a second that don't know what a hall crown is, traditional stainless steel crown with a pulpotomy or potentially an extraction again. The 8-4, is similar options for the 7-4, and then the non-cavitated carious lesions, our options are, essentially sort of fluoride-like materials. So if we summarise them into treatment, we've got a really minimal care there. So it's extract 5-4, bit of silver fluoride, or just normal fluoride. We put a Fuji bog into the 7-4. We review them at 4 to 6 months. That's minimal care. The question is that going to leave them in a good outcome long term? We then got ideal care, which is pulp stainless steel crown on 7-4, because we're a little bit uncertain on the depth of it. 8-4 stainless steel crown and SDF to non-cavitated lesions. And then we've sort of got the in-between one, which is like hall crowns in the 7-4 and 8-4, and silver fluoride for these sort of non-cavitated lesions. So minimally invasive dentistry, and this is the sort of section we're going on here. This is the new standard for dental care these days. So as most of us all are aware, that dental care is, it's not an infectious disease, it's dysbiosis. So it's a behavioural sort of disease that's mediated by a lot of other environmental factors. So a cavity is just the outcome of the disease process. And this is why we see that if we constantly just fill holes, you'll find that the patient's continuing to come back to you because we haven't addressed the underlying problem. And this has really changed the way that we're beginning to treat carious lesions, particularly over the last 10 years. And this is really important in kids because in many cases now, we can actually avoid invasive care. And in this sense, look, we can't avoid invasive care on the 5-4, but can we avoid invasive care on other teeth? So for those that aren't aware, silver fluoride is a new material, even though it's been around for about 70 years in Japan. The products available in Australia are the Creighton Silver Fluoride, which is the top left, and the Riva Star. The reason we've put a cross through the Riva Star is that it's a very basic material, which means you have to put rubber dam on it to actually use it. So if you've got a kid that you can't treat in the chair because they're not overly compliant, I can't see how you can get rubber dam on them to put Riva Star on without burning their gums. So you use Creighton's. The one on the far right is one that's made in America. It's not TGA approved in Australia yet, but you know, it's very successful. It will arrest 70% of carious lesions. And, you know, it's been written up in several places. This is what it looks like, but it looks bloody horrendous. But they're arrested carious lesions, and that's sort of how you go through. The instruction manual sort of come with it. When you're doing it for intraproximal lesions, you can use Superfloss and just apply it through there. You can see that it's a bit out of focus, but on the dental mirror, you can also see where there has been previous silver fluoride applied. So it won't stain healthy tooth structure. It will only stain tooth structure that is affected with, you know, demineralization or hypomineralization defect. The issue with this stuff is its lethally ability to stain. So I've done it before where I've pulled the floss out the side of the tooth and I wasn't paying attention. And, you know, I've used one drop there, you know, a bit that's on a micro brush, and I've managed to paint the patient a nice moustache. So you've got to be really, really careful with this stuff, but it works well. It will disappear in a week if you get it on the skin. The other option here is a Hall crown. So a Hall crown is just a modified stainless steel crown. So what we do is we put separators, and anyone that can put a band on a tooth or has ever done a space maintainer before can do a Hall crown. It's just a space maintainer with a roof. So all you do is you place the separators prior, and you can do this on cavitated carious lesions as well. You prick an appropriately sized crown that's going to fit on. You don't try and push it the whole way down, but otherwise you're going to get it back off. So then you pick one that's the best fit. You don't just pick a massive one. You load it up full of cement and you squish it on. And the reason it works, and what we explain to parents, the reason it works is because some of us ask us, why don't you need to drill all the bacteria out? Well, look, if we got a human and put them under a ton of concrete, they're not going to survive. And that's exactly what we're doing to the bacteria. We're sealing this in. And this is why Hall crowns work in comparison to Fuji blobs and things, because you have an imperfect seal there. So when we look at restorative material success, you know, your stainless steel crowns are quite high, and your resin composites and GRCs are much lower, and they substantially decrease when the size of the cavity increases. So when we look at our specific patient, what can we do? So do we just spray some SDF around everywhere or put some GRC everywhere? And once again, that's not a long-term solution. Even if we put SDF on the 7.4 and put GRC in there, yeah, you've bought some time, but that is an imperfect seal and it will not cure it. You will still be extracting that tooth at some point in the next 6 years. So there is a lot of information going out there, and some of it is a bit of misinformation in that SDF and GRC is going to save everything. It won't. It's more appropriate to use like an occlusal restoration where you've got good margins that you can bond to, because without a seal, you will get bacteria going on. So can we do a Hall crown on the 7.4 and 8.4? The 7.4 is a bit touch and go. We really like to see at least 1 millimetre of dentine from the cavity to the pulp. We're very confident with our symptoms. You can't pulp test kids' teeth, but it does truly sound like reversible. And the parents, the only other option for him is he'd tolerate one extraction. He's not going to sit through a pulp stainless steel crown. So therefore, if we want to avoid a general anaesthetic, we have to trial it with the understanding that if it fails in the next 3 to 6 months, it's going to be another extraction. The question is, do we do a space maintainer when we're taking the 5.4 out? Look, that would be ideal because the 6 is not through. When the 6s are through, you don't need to necessarily do space maintainers on Ds, and we don't commonly do them. But in this sense, it would be ideal. And in this case, the parents declined it. They didn't want to do it, and that's fine. They'll just deal with the space loss down the track. And silver diamine fluoride applied to the non-cavitated lesions, so in quadrant 2, 3, and 4, you know, that's going to be really quite a reasonable option. And we'll just retake the x-rays in about 4 to 6 months. So the question you got here is, what would we do in level 3? It's pretty much exactly what we did. You're doing minimal care there. Well, there's no aerosol generation in any of this. So you would leave the extraction for a bit later and try and knock the Hall crowns out first. And you can do both at the same time. You can do the silver diamine fluoride at that time as well. And then your second visit or third visit, you look at extracting the tooth. You know, that's quite a conservative treatment plan. That's sort of minimal intervention. We're not doing too many, there's one needle involved in the whole process. And we're pretty confident that's going to work long term for outwards of 6 years without a great deal of failures. And that's, you know, that's what we did. So there's some big benefits there. The main uncertainty obviously is that cerebral fault. That is really borderline. But we actually wanted to show you a sort of borderline case to sort of fit in with what we're doing now on these sort of level 3 restrictions. Okay, I'm going to pass it back off to Sarah now, and she's got the final case to run through.
So good evening again. I'm going to present another trauma case, but in the primary dentition now. This trauma happened to a 22-month-old fit and healthy boy, and he fell on the side of his bed head and intruded his tooth number 5-1. There's a lot of bleeding and crying, and Mom was quite a bit distressed, but there is no other injury. He did not hit his head. There is no loss of consciousness, no nausea, vomiting, and no neurological deficit. The only extraoral injury noted was a mild abrasion on his lower lip. Once again, also for primary traumas, we run through a set series of questions similar to the IADT assessment. So after the extraoral examination, we conduct a comprehensive intraoral examination. We check for mobile and displaced or missing teeth. We assess the occlusion, bony discrepancy, check the soft tissues for trauma, laceration, hematomas, and you particularly need to check under the tongue, as you may not see a hematoma unless you look for one there, but that could be the sign of a jaw fracture. The difference for primary teeth is that we do not usually perform vitality testing, as it's not reliable. In this case, the findings included age-appropriate primary dentition with unerupted ease, moderate oral hygiene, a severe intrusion of tooth number 5-1, with approximately 75% having been pushed in, and no mobility intrusions commonly. No mobility. Intrusions commonly look worse clinically than what they actually are because of the soft tissue swelling. So when you're looking at severity of the intrusion, you got to make sure that you're comparing to adjacent teeth. I also noted a bulging of the buccal bone in the region of 5-1, likely indicating that the root tip was displaced buccally. There's some demineralization on the buccal of teeth number 5-2, 6-1, and 6-2. There's no damage to other teeth and no anomalies in occlusion caused by trauma. So what's the next step? A radiograph again. So it's important to get a radiograph when you get a trauma, even when there's just primary teeth. You want to assess for fractures, for example, but particularly for displaced teeth, it helps to show which way the root's gone and if it's moved towards the adult tooth bud. For example, in the case of an intrusion, if the tooth looks shortened, it normally means that the apex has moved labially, so away from the permanent tooth. If it looks longer, then it's the opposite. It would indicate that it could have been moved. It's more likely to have been pushed towards the adult tooth bud. It helps to make a decision as to keep or not a baby tooth. So an X-ray at the time of trauma will also give us a baseline to compare to at future follow-ups appointment. It can be challenging to even do the examination, let alone the radiograph. So sometimes you may need the parent to help you hold the child to get a radiograph. But it's crucial that you get one. To make it easier for parents to hold, we like to take the film to a paddle pop stick. We normally use a size 2 film for radiographs of primary anterior teeth. In this case, radiographic findings included a displaced and intruded number 5-1, and tooth number 5-1 looks shortened, so it's confirming our suspicion from the bulging of the buccal bone that the apex has moved labially, so away from the permanent tooth bud. There is no fracture and no damage to neighboring teeth. And we also noted fully developed root length of the primary maxillary incisors, but with large pulps. The diagnoses for this case included a severe intrusion of number 5-1 with the apex displaced labially, initial caries, demineralization on the buccal of teeth number 5-2, 6-1, and 6-2, no damage to remaining teeth, and a mild abrasion on the lower lip. So in primary trauma, what are our priorities? Well, it's preservation of the permanent teeth and minimization of additional complications if possible. The management depends upon the diagnosis. For example, if the tooth was intruded into the permanent tooth, an extraction is required. This is why a radiographic assessment is so important. So let's run through the options available and pros and cons. Pros for extraction include that it can avoid ongoing follow-ups and associated fees, radiographs, time off school or work for parents. It's a definitive treatment, so there's no need to worry about complications with the tooth or teeth involved, such as infection, pain, and swelling. If canines are in good occlusion, usually there will not be space loss nor long-term speech issues. And sometimes it's the only option to help limit issues to permanent teeth. For example, if a tooth has been displaced towards an adult tooth bud. Cons for extraction include cooperation. It can be limited for young patients, so it could require protective stabilization, which could then create ongoing dental anxiety, especially if the child's over the age of 3. Or we may even need a general anesthetic. It's also less aesthetic, and another con for extraction is that the prognosis is actually quite good for trauma to the primary teeth, especially when the child is young and has immature teeth. And many traumatized primary teeth end up doing fine. So why would you extract them? Pros for conservative management includes, well, less behavioral issues, as you only need follow-ups. It may actually help get the child desensitized to the dental environment if they've got any anxiety. It's more aesthetic, and the prognosis is quite good for most primary traumas. Cons for conservative management include many appointments required, and the tooth may still need to be extracted in the future. This comes with the financial and time cost for the parents. Parents really need to understand the importance of monitoring the tooth or teeth closely, as if they fail to do so, there can be long-term consequences. So parents that aren't motivated aren't great candidates for monitoring, especially for quite severe traumas like the ones that we just show you. There are risks of complications such as pain, swelling, and infection if we decide to monitor the tooth. And also the tooth may discolor, which does not necessarily mean that it's dead, but it's just, it can be a bit less aesthetic. So what did we do? In his case, we decided to monitor. Mom was very motivated, and it also allowed me to review him for his caries risk and to apply fluoride varnish. We can see the apex here on the 1-month review radiograph, but given that he was quite difficult to take x-rays on and that clinically things appear to have improved and healed quite well, I decided not to retake it then. On the 3-month review radiograph, it looks like there's a little bit of resorption on the distal aspect of the root, but there are no signs or symptoms of infection, so we decided to keep monitoring. Commonly, these teeth will resorb and exfoliate naturally. So they'll exfoliate prematurely, but on their own, you won't need intervention. When it's just resorption and no radiolucency and there's no other signs of infection, I normally just let nature run its course and let the tooth fall out on its own. You can see on both the x-ray and the photo how well number 5-1 has re-erupted. It's almost back to its original position. I'm sorry about the white stuff on the photo. He was moving quite a bit, so I got some fluoride varnish everywhere. But the initial caries lesions appeared to be stable, and Mum's done a really good job with his oral hygiene and has stopped on-demand breastfeeding. So finally, the 6-month review. So the angle is different on this 6-month review radiograph, but it looks like there's still a bit of resorption, but no radiolucency on number 5-1, and the lamina dura can be traced around the tooth. So just a quick recap here to assess how well some of these traumatized teeth can do. So here are the photos from start to finish. And now the radiograph. So you can see on the x-rays as well the healing potential of primary teeth. Once again, management is dependent upon the type of trauma and the diagnosis. So to review, for primary trauma, the 2 types of treatment are primarily extraction or conservative management. Observation in several cases will be okay, depending upon the type of injury, but you really must get a good follow-up. The possible complications that we need to be aware of include necrosis, which can cause pain, or issues to the permanent tooth, such as enamel defect, displacement, or even infection of the adult tooth as well, but that's quite rare. You can get some ankylosis, which can then lead to failed eruption or ectopic eruption of permanent tooth. And so it's really important to monitor these teeth until exfoliation. And there's also a risk of having facial cellulitis. So,
awesome. That's it. That's the 4 cases. So we've sort of tried to cover something there, which is going to hopefully cover a few of the things you may see at this point in time. So, you know, primary trauma, permanent trauma, MIH, and caries. And also, we're just trying to look at, you know, obviously what we can try and do in ideal periods of time. If anyone's got any questions, please welcome to send them through. We've had a couple that are coming in. We're happy to answer them. Look, a question we got is, when you use silver diamine fluoride, do we use potassium iodide after? Look, the Creighton's silver fluoride is 2 bottles.
The Rivastar is 2 bottles. And actually, the issue with the potassium iodide is that it will prevent the fluoride and the silver to penetrate the tooth as deep as it normally would. So it actually decreases its caries arrest potential, and also it will end up staining anyway at one point. So it may look better initially, but in the long run, it's not going to be much better anyway, the color.
Another thing too, and this is a really good point, is that it's a separate question. It's sort of about, you know, I thought high-speed drills were out under level 3 restrictions. Look, this is tough. They're not out entirely. They are significantly restricted. So in the sense of you need a high-speed drill for your spectropulpotomy, look, if you don't use a high-speed drill, you're looking at having lifelong permanent effects and issues to the child there. So your main issue that you want to try and do to get around that is use your hydrogen peroxide rinses prior, you know, and using rubber dam. But your justification for using a high-speed drill, for example, in a permanent trauma for a spectropulpotomy, it would be an indication. I mean, it'd be nice if you had N95 mask or P2, but obviously it's quite challenging to get that type of equipment in at this point in time. But yeah, look, it's stuffed. It's really hard. This is a really hard environment to work in at the moment. So look, if you guys ever get any questions about patients that you're seeing, or you want to work out what's going on, I don't know if many of you know, Sarah's actually 22 weeks pregnant, which is pretty good. So she's actually stopped working about 3 weeks ago. So you're only left with me, but with Sarah, she can take lots of phone calls at this point in time. So if you ever get any questions, you can just give us a call. We're happy to we'll give you our mobile numbers as well, if you want to have a chat to us as well about any cases or anything that you come up with. So I guess, does anyone else have any other questions. And thanks for the congratulations. We're pretty pumped. I think that's about it. Look, I hope that was good. We hope that everyone had education on making putty keys. You just need lab putty, don't you, pretty much?
Yeah, we just mixed like the heavy body putty, the 2 consistency paste, and then just got the patient put it around the plastic bit of the XCP, the disposable one, because you got to keep it for particular patient, and then you just get them to buy. But if you want to come in, or maybe you can make a video. It's a bit tricky to explain.
Yeah, we can do a video. If anyone wants, we can do a video. We've also got some videos of us doing hall crowns as well. So if anyone wants to know how to do hall crowns, we're very happy to send you a video of that as well. And we make up like a blog site for Paediatric Dental, which is called kidsdentaltips.com.au. And the next one we're going to do is hall crown. Just so that, you know, if people, that is something they may be able to do as well. So thank you, everybody. We know it's 8 p.m, but we all hope you have a really nice night. I hope that everyone's enjoying themselves in forced unemployment time at this point in time as well. Awesome. Good night, everybody. See you later.